Who are here, all the speakers who are here. Today, we are very grateful to Dr. Sathi Devi, who is the head of Glaucoma Services at Narayan Netralaya, Bangalore, to have with us. We have Dr. Kumar Ravi, and we have Dr. Maneesh. We have Dr. Sagar Bhargava also with us. Dr. Sathi Devi will be talking on angle closure glaucoma, followed by Dr. Ravi and Dr. Sagar Bhargav. Dr. Maneesh will be moderating the session. I would like to request, without wasting any time, to please request Dr. Maneesh to take over, please.
Welcome everyone. So we'll be starting with our first presentation. Madam, you can share your slides. So each presentation will be of around 20 minutes. We do have a margin of 2 to 3 minutes here and there. And follow after that, we'll have half an hour time for question and answers. So I'll request all the participants to share their questions in the chat box and to keep their microphones muted during the presentation so that there is no disturbance. You can also keep your videos off, so that will help in proper streaming of the slides. I think Madam is ready with her slides. So Madam, please, let's start the slide.
A very good evening to one and all. And thanks Dr. Maneesh and Dr. Sinha for this opportunity. So today I'll be talking on primary angle closure disease, and I would be talking basically on the diagnosis and management. However, I will touch upon the classification just because the management of this disease would depend on the staging of the disease. So I know that the previous sessions have already covered a lot of these things in detail. So I will be talking about the classification in brief before we start off with the diagnosis. So if we look at the older classification and terminology, they were divided into acute, subacute, and chronic, which was mostly related to the kind of symptomatology which the patient was experiencing because of the glaucoma. So this was something which was definitely very familiar to clinicians. It was easy to understand. However, there was no emphasis on the presence or the risk of significant loss of visual function. So it was only about the symptoms and the presentation, and we had no clue about the amount of visual function loss that may have been there with this kind of classification. So this also did not help us in predicting the prognosis and does not guide us in planning management. So the more recent classification that we now use is the ISTUO classification that was published by Foster et al. So he proposed 3 conceptual stages in the natural history of angle closure. In the first stage, there's simply iridotrabecular contact. In the next stage, you see signs in the anterior segment. This could be either in the form of raised intraocular pressure or the formation of peripheral anterior synechiae. And in the next stage, you see glaucomatous optic neuropathy changes. So first, to define what is a occludable angle. A occludable angle by definition refers to iridotrabecular contact which is seen for more than 270 degrees, that is about 3 quadrants of the filtering angle. That's the trabecular meshwork is not seen during gonioscopy. Of course, it's most important to understand that gonioscopy has to be done in the appropriate testing conditions. This 3 quadrant ITC was first described by Akel et al. And this was what was adopted by Foster. However, Professor Ravi Thomas used 180 degrees because this was more clinically what we see, that even with 180 degrees, we do see significant amount of angle closure. So if we look at the stages, on the left hand side, you have the stages, the PACS, that is the primary angle closure suspects. Then you have the primary angle closure, and finally primary angle closure glaucoma. In suspect, you only have ITC or the iridotrabecular contact, which may be 2 to 3 quadrants, but the pressure is normal. There is no synechial closure, disc and fields are normal. In the next stage, that is primary angle closure, you again have the ITC, but here you see that the intraocular pressure is raised, but there is only a positional closure, or you might also see synechial closure. So it can be one or both of these points, which will then define it as a primary angle closure. At this stage, the disc and fields are still unaffected. In the last stage, which is the primary angle closure glaucoma, you have all these along with evidence of disc damage, which translates into field loss. So the other features that also fit into primary angle closure stage is when you see that there is trabecular obstruction by the peripheral iris has occurred, and features that are suggestive of this, such as excessive pigment deposition on the trabecular meshwork that's seen on gonioscopy. If there are signs of anterior segment ischemia, which can occur during an acute attack, which may be in the form of iris whorling, loss of pupillary ruff, or sectoral iris atrophy, subcapsular lens opacity such as glaucoma flecken. These, like I said, are seen post acute attack, which may not have still caused disc or visual field damage. Now, with all this, we understand different stages of the disease. However, we still do not understand the mechanism that is involved. So this classification that was devised by Rich et al. Talks to us about the various mechanisms that can cause angle closure. So he proposed that blockage happens by forces that act at 4 successive anatomic levels. In a given eye, multiple mechanisms are likely to work, and this is then called as mixed mechanism angle closure glaucoma. So what are the 4 levels? One is at the level of the iris, which is most commonly the pupillary block glaucoma. At the level of ciliary body, which is caused by most commonly the plateau iris. By the lens, that's phacomorphic glaucoma, and vectors posterior to the lens as in malignant glaucoma. So here in the image in figure 1, you see that there is a convex iris that we are seeing, a very well-defined ciliary sulcus. The ciliary process is normally positioned. You can see that the angle is fully closed in this situation. In the next, we are seeing that in an eye which goes, such an eye that can go for acute attack, the patient can develop the supraciliary effusion. That's the space that we are seeing here above the ciliary body. In this is a plateau iris. So you can see this is the ciliary process which is opposed against the peripheral iris. So even after doing a YAC PI, the iris is unable to fall back because this role of iris ciliary process holds the peripheral iris forward. This also is a plateau iris, but you can see here the thickness of the iris. This is quite a thick iris root, and that is further adding to this very, very narrow occludable angle. Also in plateau iris, you can see that the iris is more or less straight, unlike the convexity that you see here. Hence, the central depth appears to be normal. Now, what are the risk factors that are there where the patient can develop primary angle closure? Increasing age is a risk factor. So the depth and the volume of the anterior chamber decreases with age because of the normal increase in the thickness of the lens with age, and prevalence per decade almost approximately doubles. In female gender, it is 2 to 4 times a greater prevalence. Asians are known to be more prone to this kind of disease. Genetic predisposition, if there's a family history, the risk for siblings, parents, or children is almost 3.5 to 6 times higher. The other biometric features that can act as risk factors are a shallow anterior chamber depth, a thicker lens, increased anterior lens curvature, a shorter axial length, a smaller corneal diameter, or a smaller radius of curvature, and hyperopic eyes. All these are at a higher risk. Now, if we look at coming to the actual diagnosis itself, in the history, one has to be careful in eliciting history regarding medications that the patient may be using, family history, any other systemic issues that may necessitate frequent dilatation as in a diabetic, and whether the patient has any symptoms at all. During the slit lamp examination, one looks at the anterior chamber depth. You can do a von Erich's test to look at the peripheral anterior chamber depth. Look for features such as iris atrophy, sphincter atrophy, the absence of a pupillary ruff, or the presence of glaucoma flecken. Intraocular pressure measurement is done in the routine manner. This has been dealt in the previous classes, so I won't go into that. So here you're seeing a very shallow anterior chamber, and you can see in the picture here, in the figure here, that there is a convexity of the iris that you can notice. This shows iris atrophy. Here you can see absence of sphincter, as well as pupillary ruff, which is absent in this area, glaucoma flecken on the anterior lens surface. You can see clumps of pigment on the endothelium, and this is actually post-attack. There is a patent PI that we can also see in this picture. The most important diagnostic method that is required for the diagnosis of this disease is to do an indentation gonioscopy, because this is what tells us regarding the presence of angle closure. So this is absolutely must. Every postgraduate should learn gonioscopy and be able to identify angle closure in a patient who is suspected to have glaucoma. So again, like I said, appropriate testing conditions. So what does this mean? The room illumination, the ambient illumination is dim. Your slit lamp illumination is dim. The slit beam itself, the height as well as the width is kept to a minimal. You do not want bright light causing constriction of the pupil. And you would want to also make sure that the patient looks straight ahead when you're doing the gonioscopy. So on gonioscopy, you look at the configuration of the iris. Typically what you see is a convex iris. You try to assess what is the extent of contact of the peripheral iris with the trabecular meshwork. And then by doing indentation gonioscopy, you need to decide whether this is appositional angle closure or whether there is a permanent synovial closure. By indentation gonioscopy, I mean you press the central part of your gonio mirror onto the central cornea. This then pushes the aqueous into the peripheral angle and opens up the angle if there is only appositional closure. You could grade the angle, but typically I do not actually use a particular method to grade. It is important to identify each structure that is present in each of the quadrants and make a note of it and see what is the change that happens with indentation to these structures. Also make a note about the pigmentation of the trabecular meshwork and, like I said, the extent and presence of peripheral anterior synovium. So in this picture here, we are seeing that this is the peripheral iris. You see a white band here and there is a brown band here. So if we presume that this is the scleral spur and the trabecular meshwork, you would label this as an open angle. However, if you do indentation gonioscopy, you realize that your peripheral iris is here. The white line that you were seeing is actually this, and this was the pigmented line that you were seeing. And with indentation, what has now opened is that this is your actual scleral spur. This is the trabecular meshwork, the pigmented line, and this was only the pigmentation that you were seeing on Schwalbe's line. So what you see on the left is actually a closed angle, which is now opening on indentation. The gonioscopy can be a little subjective, and if you are looking at quantitative measurement, then you would want to use some instruments like the ASOCT or the UBM. However, you must remember that with all these techniques, we are still unable to differentiate appositional angle closure from PAS, and these are not substitutes for gonioscopy. So you must do gonioscopy before you even think of doing. These can only be additional tests that you could do, but they will not be a substitute for gonioscopy. So in UBM, the big advantage that you have is that you are able to visualize the area of the posterior chamber and the ciliary body, which is something that you cannot see with the gonioscope. So here you can see that the ciliary processes are turned forward, and this is again plateau iris. With the ASOCT, various angle details are very clearly seen. The Schlemm's canal, scleral spur, Schwalbe's line are all very well visualized. And with the Swept-Force OCT, you can get a 360-degree imaging of the angle as well as the iris. Various parameters such as the width of the angle, the volume of the iris, and the anterior chamber volume can be measured repeatedly without changes. So this helps in a lot of documentation with objective measurements. So if you see here, this what is marked here is the scleral spur, and what you see next, the green cross here is actually the anterior most point of iris contact against the trabecular meshwork here. So this is a closed angle. In this, the end point is always in front of your scleral spur. Whereas if you look in an open angle, this is your scleral spur. You can see the trabecular meshwork here, and the end point, which is actually behind the scleral spur, because this angle is open. So you can very clearly visualize the way the angle looks. Now, this is what you get on a SWEP source. So this is the area of the iridotrabecular contact that it gives all round. So this blue area indicates that there is angle closure that's happening in a greater part of this angle, except in this little part, one quadrant here. Most of the angle here seems to be closed. So if you look at the iridotrabecular index that it gives, it tells you here that almost 93% of your angle is closed in this eye. Similarly, if you see your open angle, you can see that in this eye only 29%. Actually, it's not even 29% because you can see there is not much of blue area at all. The entire angle is open. There is an invisible range. That means the machine has not been able to detect the skin whisper and assess in 22 degrees. Hence, only this part of the angle appears to be closed. So this is how an open angle would look. So contrast with a closed angle picture, which looks like this. Now the next is to evaluate the disc. Again, very similar to POAG, cupping of the optic disc can be seen. But one thing to keep in mind is that a pale disc is often seen in an eye post-acute attack instead of the regular cup disc, because here it is more ischemia of the optic disc that we see during the acute attack. In visual field assessment, you do get what we look at as more diffuse field loss. You see more severe defect of the central field, especially in the late stages, and there may be greater asymmetry of field loss between the two eyes as compared to primary open angle glaucoma. So in this eye, you can see that there is a thinning, a notch of inferiorly and corresponding field changes. So it's important to assess the amount of damage in a given eye. The acute attack, which basically there's a complete or a near complete closure of the anterior chamber angle. This is characterized by sudden and dramatic elevation in the intraocular pressure. The patient presents with decreased vision, severe pain in the eye, as well as headache. There's corneal edema and ciliary congestion with a mid-dilated pupil. So this is the corneal edema and as well as disc edema in acute attack. Now, I'm giving a clinical picture where a patient presents with mild pain, which disappears after he takes rest. You're seeing him with a good vision of 6-9 parts. Pressures are normal, pupils are reactive, but the only telltale sign is the central DM fold. He has a shallow anterior chamber and an occludable angle in both eyes. The disc is healthy. Diagnosis here is of an intermittent angle closure. So the patient did have a mild attack the previous day, but because he rested and because of meiosis, the attack has now got relieved. Coming to management, you again stage into the disease, and I'll try to cover each stage. So in primary angle closure suspect, where you simply have iridotrabecular contact, the prevalence is quite high, so it's quite a common thing. Not all these patients require LPI. The chance for them to progress to PAC is only 22%. We are not going to do a LPI in a given eye. It's important to tell the patient the risk of acute attack, the risk of developing glaucoma later, the need for follow-up, and what are the symptoms that he needs to watch out for. So where do we do LPI if we see a primary angle closure suspect? If it is a below eye of a patient who already has PAC or PACG, if there's a family history of angle closure glaucoma, if there's a need for repeated dilatation as in a diabetic or somebody with AMD, if he's symptomatic, if he gives a history of colored halos, headache or blurred vision, if you notice patchy pigmentation of the trabecular meshwork suggestive of intermittent iridotrabecular contact, patients who are on medications are likely to precipitate angle closure as if the patient is on antidepressants, antihistaminics or salbutamol, which can precipitate angle closure. In a patient who's anxious and who demands or who wants a YAC-PI, you can go ahead and do it. Somebody who does not want to take the risk, somebody who has poor access to emergency care, these are the situations where you would want to go ahead and do a LPI. If pressures are already raised along with the LPI, you would then want to treat the elevated intraocular pressure. You start the patient on medications. In this group, the need for glaucoma surgery is highly unlikely. Also, sometimes when you remove the cataract in these eyes, the number of glaucoma medications may actually reduce. But it is important to follow up these eyes to ensure that the IOP control is adequate and the disc continues to remain healthy. Coming to the glaucoma stage, again here the aim is to not only keep the remaining part of the angle open, you want to control the pressures and also prevent worsening of the disc and field damage. So there is already some amount of damage, but you want to ensure that it does not progress. Again, you do a LPI. You start with medications. You can even give additional SLT or selective laser trabeculoplasty to the areas that are open. You then assess the extent of residual angle closure. If this does not control the intraocular pressure, one may need to consider a trabeculectomy with or without a cataract surgery. Medications, all classes of medications can be used. Pilocarpine does help in a big way, but you do not want to use it as a substitute for your PI. So Pilo can be used only after you've done a PI. However, you don't want to use it long term because it tends to cause AC shallowing and anterior movement of the lens iris diaphragm. Prostaglandin analogs also work well in this situation. Trabeculectomy can be done, like I said, if all these measures fail. One thing that we need to keep in mind, it is routine trap, but the chances for having a shallow AC or a flat anterior chamber with choroidals can be quite high in these eyes. Malignant glaucoma is a common complication. So some of the steps that you need to take on table is to ensure that you form the chamber on the table, make sure that your scleral flap suturing is tight, remove the lens if it is cataractous, adequate cover of the stoma by the scleral flap must be ensured, make sure you do not have buttonholes or leaks, use atropine postoperatively, and a prophylactic sclerotomy in high-risk eyes such as Sturge-Weber eyes are useful. Briefly, I'll go over acute angle closure attack. So again, medical treatment. Here, additionally, you may want to give topical steroids and systemic analgesics to take off the pain. IV mannitol, glycerol may be required. If iridotomy is difficult, a peripheral iridoplasty may be required. This is a laser procedure in which the peripheral iris burns are applied to allow the peripheral iris to contract and move away from the angle, thus breaking the attack. Surgical iridectomy, if it is not possible to do a laser PI, which is generally never these days required. If the angle closure has lasted long and if there's extensive synovial closure, one might require to do a trabeculectomy with or without a phaco, or even a phaco alone is possible. The most important thing is to break the angle closure attack as early as possible. So post YAC-PI, you need to control the pressures, reevaluate the angle, see the extent of synovial closure, and evaluate the disc and visual fields to assess the amount of damage. If the angle closure attack lasted longer, if the repeated attacks were there, if there's extensive PAS, higher pressure on presentation, larger CT ratio at presentation, these are predictors that the patient may end up with incisional surgery. So this was, I think I already spoke about this.
Can we request everybody to please put their mics on mute, please? Maneesh, can you take over that?
Locate who has switched it on. Mr. Gupta, can you just mute that person whose mic is on? Madam, as you can, I think you can carry on, madam.
Okay. The success rate of trabeculectomy is lower in eyes with acute attacks. Goniosynovialisis is a procedure where the peripheral iris is mechanically released from its adhesion to the angle under viscoid cover. Ideally, it's done with visualization of the angle. It's generally helpful in post-acute attack eyes. However, it must be performed before there is irreversible damage to the trabecular meshwork. Clear lens extraction is a controversial issue. Increasing lens thickness and relative anterior lens position can be ameliorated by removing the crystalline lens. In eyes that are post-acute attack, early phaco versus LPI, they found that phaco group fared better. So this is an option, but one must be good at doing phaco surgery and ensure that undue complications should not occur. In the EAGLE study, which was in the eyes with angle closure and glaucoma, the difference was only 1 millimeter with clear lens extraction, but one has to understand that loss of accommodation and risks with clear lens extraction exist when you plan for this surgery. Gonio data is missing in the study, and most of the study included only early glaucoma. I think I'll skip this because I'm running out of time. So plateau iris is something that you see because of this double hump sign. There's a peripheral, I already spoke about the ciliary processes that tend to hold the peripheral iris forward. The only thing that works better differently here is that iridoplasty helps in releasing the or getting the peripheral iris away from the angle. So I'd like to conclude by stating that it is important to recognize angle closure. Like I said, gonioscopy is something that you must master. It's of utmost importance. It's almost preventable if it is detected and treated early. Treatment guidelines are based on the stage of the angle as stage of the disease as well as the mechanism of angle closure. Long-term follow-up is absolutely essential to monitor for progression. Thank you.
Thank you, madam. I think it was really complete discussion about angle closure disease, starting from the definition, classification, diagnosis, and management. Till now, we don't have any question related to angle closure disease, but we'll request you to be with us so that at the end of all the three presentations, we'll be discussing all the questions related to all the three presentations.
Sure.
One important thing, madam, we have seen that postgraduate students, they often find indentation gonioscopy very difficult. They are more comfortable using 1 mirror, 2 mirror, and a lot of them are little reluctant using 4 mirror gonioscope. So any tips you like to share with them, that all of them who want to shift to indentation gonioscopy, what are the problems they may encounter and how to tackle that?
So when I agree that it may be the only issue with a 4 mirror is that it tends to move on the eye a lot, unlike the 3 mirror lens, which can stay well in place. The angle structures, when they need to learn regarding seeing the structures, they can learn it on a 3 mirror. Once that is done, it's actually so much easier with a 4 mirror, because all you need to do is to learn. The only difference that you need to learn is to ensure that it stays stable on the cornea, and then it becomes easier to see all the 4 quadrants nearly at the same time, and how to do the gentle indentation, because that is ultimately what differentiates between synechial and appositional closure. So they must learn to do the gonioscopy with the 4 mirror and learn indentation gonioscopy.
I think just a matter of time. If you keep practicing,
Absolutely.
you will definitely master it.
Absolutely.
When there are few questions have come, madam. One is a very interesting question. What is in PACS, what is the loss if we do a prophylactic PI, since they have 5 to 6% chance of acute attack in lifetime, and we don't know who will have attack? Why not better do PI prophylactically? So basically, I think what is the harm in doing PI in all cases with PACS? That is a question I think Dr. Arshad has want to ask. Yeah.
So agreed. Like I said, all these risks are definitely there, but we need to understand that it is only maybe 1 in 5 or 1 in 10 who is eventually going to get the problem, and it may be difficult to treat. So with increasing age, you're going to see nearly 1 out of 10 patients who will have a narrow angle. So you will end up doing a lot of YAC-PS, which may or may not really be necessary. So the chance for them to have a problem is slightly lower, which is why we are just trying to target those eyes that are at higher risk. However, if you discuss with the patient, and like I said, if the patient feels that he does not want to take the risk, you can go ahead and do the laser procedure.
There's another question. What is goniosynechia and what is the difference between high PAS and normal PAS?
I'm really not aware if there's a difference like this, unless you can.
It's more of a subjective thing rather than any classification of what is high and what is.
Yeah, so I don't know whether this refers to, for in plateau iris, we look at the amount of closure of the angle that you see. So the height to which the trabecular meshwork is closed by the peripheral iris. I don't know if that is what they're referring to.
In some textbook I've seen, madam, when you can see the synechia on slit lamp, where the synechia has come anteriorly beyond the solve line. Sometimes they refer as a high PAS, but I don't think there's any clear-cut differentiation. Another thing, madam, how is topical glycerol used in acute primary angle closure? You like to share how you use topical glycerol if you use in these patients?
I personally have never used that, but probably if you just want to clear the epithelium, maybe that helps in getting a better view of the angle. But in this kind of a situation, which is what I was talking about, when you cannot do the LPI because of corneal edema, you could try doing the iridoplasty, which then helps in breaking the attack and reduces the pressure, and then you can go ahead and do the LPI. So,
thank you so much, madam. I think we'll take further questions after all the presentation. Dr. Satyajit, we'll have now presentation with by Dr. Kumar Ravi.
Thank you, Thank you so much, Dr. Sathi Devi, for that beautiful presentation. Thank you so much. We are really very grateful to you. Now we would like to welcome Dr. Kumar Ravi. He is a consultant at BBI Foundation, Kolkata. He did his fellowship at LV Prasad Eye Institute, and then he was a consultant at Shankar Netralaya, Kolkata, also in the glaucoma services. I would like to welcome Dr. Ravi, please, for his presentation. Dr. Maneesh.
Yeah, Ravi, you can share your slides. So Ravi will be speaking on ocular hypertension, and a lot of PGs have told us they do get a lot of questions on ocular hypertension. So next 15 minutes, Ravi will be giving us an overview about ocular hypertension. Ravi. Ravi, can you share your slides?
He was just here, suddenly.
Yeah, you just see Ravi. I think suddenly maybe the connection is lost. I'm not able to locate Ravi.
So in the meanwhile, in this primary angle fluorescent glaucoma, some of these patients who are steroid responders, and you do a YAG PI, and then post-operatively, post-laser, you want to give steroid or mild steroid. So how do you balance that? You give a mild steroid and they are steroid responders. How do you take care of that?
Madam, you please unmute your mic. Madam.
I'm sorry. Yeah, am I audible now?
Yeah, madam.
Yeah. So one, yes, steroid responsiveness itself can give rise to a spike in the pressure. Often the process of laser itself, which tends to cause inflammation in the eye, and the release of pigments, which can then tend to clog the trabecular meshwork, also tends to cause a spike in the intraocular pressure. This is something that we need to watch out for. Typically, you can check the pressure 1 hour after you have done the laser procedure, and then call them back again a week later. And if you do see a spike, you can always put the patient on topical glaucoma medications, brimonidine. I personally don't give these medications prior to the laser, but yes, there are people who also give brimonidine or even dorzolamide prior to the laser procedure itself. If the pressure spike is on the higher side, you might want to give some systemic acetazolamide also.
Thank you, madam. I think Ravi, are you? We're just seeing slide.
So is the slide visible to you?
Yeah, I think it's visible now. Thank you. You can start the presentation.
Okay. So in the beginning, I would like to thank Dr. Satyajit and ABI Institute for having this program, and I would also like to thank the visible and the invisible team who is making this a success. So coming to my presentation, the heading is Approach to Ocular Hypertension. I have no financial interest in the presentation. And before going into the presentation, these are my PG days, my fellowship days, and later days at my Shankar Netralaya, just to share that I have not forgotten my struggle in learning glaucoma as a postgraduate and fellow. So my presentation I have split into 2 parts. First one will be understanding ocular hypertension, and then we will go into to see how to write in the exams if a question appears. Now, this is the number that is ingrained in our brains. 21 means everything is okay if it is pressure is 21 or below. The moment it is above 21, we are into the danger zone. So let all of us move into the danger zone and see how dangerous actually a pressure of above 21 is. So who is a patient of ocular hypertension? A patient of ocular hypertension is one who has open angles, whose fields and disc is normal, but his IOP is high. So if you see this graph, there are patients who have pressure in this green zone, which is above 21, but they do not have any field changes. So the patient whose pressure is above 21 without any field or angle changes would be classified as ocular hypertensive. So sometimes it becomes too cumbersome to understand with what I've taken definition and everything. So let's hear a story. So in the year 1995, twin brothers, say, let's call them P1 and P2, they were 39 years of age and they were evaluated for glaucoma. Both of them had open angles, their disc was normal, and they had normal fields. But the problem was they had pressure of 24 in both the eyes. Rest all parameters were normal. So based on the knowledge at that time, high pressure means glaucoma. So they were started on glaucoma drops and they were asked to review. These patients were on follow-up for 5 years. So first patient P1 followed the advice sincerely. He reviewed regularly. He had his field test done for 5 years, and then he was marked as stable. And second patient P2, he says, forget it. I don't have any problem. I can see clearly, and he was lost to follow-up. This usually happens in our clinic even today. So after 5 years in 2000, both of them appear together. It was noted that first patient who had a pressure of 20, he was on treatment, and the second patient again, initially also and present also, he has a pressure of 24, but he is not on treatment against advice. Just all the parameters were same. Open angle, disc was okay, fields was okay, everything was fine. So after 5 years, the patient who has taken treatment and the patient who has not taken treatment, both are on same platform. Now the doubt before us is, was the treatment actually required? So this is not just our doubt. This is a doubt of many clinicians. And the answer to this, with the other doctors in the entire group of Dr. Kas, they attempted to answer this question. What they basically did was, they selected 1,636 patients, and they were all patients of ocular hypertension. And with the commercially available medicines, they reduced their IOP to 24 millimeters or below, or by 20%. These patients were followed up for 5 years, and it was noted that 4.5% of the patient in the treatment arm developed primary open angle glaucoma, and 9.5% of the patients in observation group. That means who were not taking treatment, in that group, 9.5% of the patients developed POAG or progressed to POAG. So what we understand from this? The conclusion was that medicine is definitely effective in delaying or preventing the onset of POAG. But we cannot treat everyone. So the treatment is reserved for the individuals who have moderate or high risk of developing POAG. In this study, we also found a few interesting features. This pachymetry was not in the initial study, but later they added this, and it was very important. What they saw was, if we plot a graph with increasing pachymetry values or central corneal thickness and with the rising pressure, it was noted that the patients who had high pachy, means high central corneal thickness, and low pressures, they had less chance of developing POAG. So obviously low pressure, less chance of developing, but low pressure with high CCT values, they had very less chance of developing or progressing into POAG. On the reverse, the patients who had high pressure and low CCT values, they had very high risk of developing POAG in follow-up. Another interesting thing which came out was, if we take 545 micron thickness as a baseline, then the patients who had low corneal thickness, for them, we need to correct the values of the IOP that we get on applanation. And for patients who had high corneal thickness, they for low CCT, we underestimated IOP values, and for high CCT, we were overestimating our IOP values. So we have to adequately correct that value. And one more thing which came up in the study was that if the patient developed disc hemorrhage, they were more prone or more likely to progress into POAG during the follow-up period. So in OHTS study, what we basically understood was lowering the pressure, lowering the IOP by say 22.5% is predictive. Definitely it is predictive. And the risk of progression reduces from 9.5 to 4.5 in the treatment arm. Thin cornea, disc hemorrhage, and high IOP, they are important risk factors for POAG. So ideally, if we go by the study, probably we should treat everyone treating everyone would be ideal, but it is impractical. So it is not cost effective and very poor quality of life, because a lot of these drugs have a lot of side effects like redness, irritation, and it like worsens the quality of life. So treating everyone is not a good idea. So what option do we have? Let's search for the risk factors. Let us treat the ones who are at high risk. So who are high risk cases? The high risk cases are the ones whose pressures are above 30 millimeters of mercury, or the patients who have pressures above 26 millimeters with low CCT values. So for these patients, the recommendation would be to bring the pressures below by say 20 to 30% from the baseline IOP. And these patients should be closely followed up, say 4 to 6 monthly. And they should also be followed up with field test and OCT to see if any disc or field changes are developing in follow-up. The moderate risk cases are the ones who are having IOP of 22 to 29 millimeters, or those who have a pressure of 22 to 25 with low CCT. If the patient has high myopia or a family history of open-angle glaucoma in first-degree relative, they are also under moderate risk category. So for these patients, we have to discuss the situation with the patient, and if risks are more, we can start on therapy. But if the patient is ready to follow up, possibly we can follow up every 4 to 6 months without treatment also. But it would be ideal to do perimetry and OCT examination periodically. And obviously, any patients with low pressures and high PACI, they would be under low risk category. So for low risk patients, the plan would be to observe 1 yearly. And if they don't develop any changes, we can continue observation. And if they progress into moderate or high risk group, we can start on therapy. So if the numbers are too much for our PG colleagues, so we can simply remember that if the IOP is 26 millimeters of mercury, we can possibly consider treatment. And if the pressures are below 26 millimeters of mercury, we can go for observation also. But then again, it is oversimplification. It is not the final thing, but easy to remember. Is there any role of laser? Only in cases wherein they are not tolerating medicines, we can go for laser trabeculoplasty. And any role for surgery? Very less. Only in extreme cases wherein the IOP is very high on maximum medication and the patient's pressure is not under control, we can consider surgery, but that has to be discussed with the patient. This situation is very unlikely. So now, once again, we come back to the pressure. So any pressure above 21 is not actually as dangerous as it appears. We have to see the multiple risk factors involved and then only take a decision regarding treatment. So this part was basically about understanding the ocular hypertension. And in the next part, this would be mainly for the exam going PGs. For others, it may not be that useful. So for when we are writing for ocular hypertension exam, we should cover these points like definition, epidemiology, pathophysiology, risk factors, diagnosis, differential diagnosis, treatment, and some other salient features. In definition, we should mention that these are the individuals who are at the greater risk of developing open-angle glaucoma, but yet there is no definitive evidence of glaucoma. Some examiners may want to know that they have IOP, which is 2 standard deviation above normal population range in that age. As far as epidemiology is concerned, they have a prevalence of around 2 to 6% in the population aged above 40 in Western countries, and our data suggests about 1 to 2% prevalence rate in patients above 40 years of age. The exact cause of this disease is not known, but we assume that it could be because of reduced aqueous outflow in the trabecular meshwork. The risk factors involved are baseline age. The early presentation or the early age presentation involves higher risk. Baseline IOP, higher the IOP, higher the risk. Central corneal thickness we have seen. High vertical cup disc ratio of more than 0.6 is considered as a risk factor. And in perimetry, if we see PSD changes in progressive changes in subsequent HVF, we need to count it as a risk factor. Associated risk factors are first-degree relative with primary open-angle glaucoma, if the patient has myopia, in fact high myopia, and if there are cardiovascular diseases associated, then these are additional risk factors. Coming to the examination, a detailed evaluation of anterior posterior segment is mandatory. Even though we are just doing a glaucoma evaluation, we should do a thorough examination of cornea, anterior segment, iris, lens. For disc, detailed evaluation should be done, and fundus should be evaluated in detail. The differential diagnosis would be First, primary open-angle glaucoma, pigmentary glaucoma, dramatic, and pseudoexfoliation glaucoma. So the decision to treat would depend upon patient's life expectancy, the probability of functional vision loss in future, and side effect and cost involved. As far as the treatment is concerned, the drug of choice would be PK analog or a beta blocker. And then coming to the final thing, important to note is even if we put the patient on treatment, periodic checkup is important because any patient can progress even when he is taking his treatment regularly. So periodic checkup and disc, gonio, and perimetry should be done periodically. Thank you.
Thank you, Ravi. I think it was a very lucid presentation, and all the concepts have been presented in a very simplified way. I'm sure it will be very beneficial for the PGs. What we have noted that a lot of PGs do participate in this webinar, but later on, when the webinar is uploaded on the YouTube, the number of views are much higher, 300 to 400.
We can't hear you.
Is it audible now? Am I audible?
Yes.
I think there is some noise coming.
It is from your end only.
Some noise, I think, is coming. We will move ahead with the second presentation, third presentation by Dr. Sagar. Doctor.
Before we move on, do you have any questions in the chat box?
I think Ravi, Dr. Ravi, are you there?
Yes, yes.
There is a question for you. Is the risk
Yeah.
factor scoring useful for ocular hypertension? We are getting some noise. Mr. Gupta, are you there?
Yeah, I'm there, sir, but noise is not this.
Can you, Maneesh,
All
can you
mics
take
are
your
on
mic mute? It is still there.
Even when
Okay.
I mic mute, the noise is still coming. Anyway, Ravi,
because except speakers, all the mics are on a mute.
Dr. Ravi, I have a question.
Yeah, please, sir.
In a country like India and globally also, one of the statements you made that you have a lot of follow-up patients. So especially that you don't have anything right now, but you need to come up with one.
Dr. Satyajit, your voice is breaking.
Can you hear me?
Now it is clear, sir.
So Ravi, can you hear me?
Yes,
Yeah,
sir.
your voice is breaking. It's not very clear.
I was saying we have a lot of patients who are lost to follow-up in India.
Right.
And if you have a ocular hypertension patient who you want to keep under observation,
Yes.
the patient realizes that the doctor told me that what suggestion
So your voice is a bit.
really
Your voice is breaking. The second point I could not get. The patient is of ocular hypertension, lost to follow-up, but then I missed the second part of it.
Sagar, your voice is clear.
Yeah, hello. Yeah, can you hear me?
Okay, go ahead.
We can hear you. We can hear you. I think what we can do, Dr. Satyajit, we can take that. There's another question by one of the participants. We'll take both the questions after Dr. Sagar's presentation.
Okay. Okay.
Dr. Sagar's voice is clear. Dr. Sagar, you can start your presentation. Satyajit, you can introduce.
Yeah.
I would like to thank Dr. Kumar Ravi for his presentation. Very nice presentation. We'll have the discussion after Dr. Sagar Bhargav's presentation. I would now like to welcome Dr. Sagar Bhargav, who is a consultant at BBI Foundation, Kolkata, and is director in SLR Eye and Retina Surgeons Private Limited, Kolkata. He completed his MBBS and MS from Aurangabad. He had to his credit a lot of awards. He got the Dr. Pandit Palitkar Memorial Prize for standing first in MBBS. Dr. Balchandra Mukund Memorial Prize for standing first in subject of ophthalmology in third MBBS. He has received the R. Palachandran Memorial Prize for securing highest marks in MS Ophthalmology. While working in Sagar, Satyajit was recognized as the best associate consultant in the year 2008. He was conferred upon the Dr. PLK Co-Enjoyment Award. In the year 2008, after successfully clearing his examination, he was conferred by the Pathophysiology degree also. He started LASIK Center Shankar Netale in 2011 and was the first to use the methodology to practice LASIK. He has actually panels for glaucoma and
Mr. Maneesh Gupta. Mr. Gupta, are you around?
Yeah, I'm there, sir. I'm there, sir.
I think we are getting a lot of noise, and even Dr. Satyajit's audio. Is there any technical issue? Would you like
No,
to?
sir. No, sir. In between, your voice was also coming, but now it is very smooth. It is very clear voice. If you wish, I can mute again to all the participants. But again, the speakers need to unmute their mics. Should I mute all?
do that. Do that.
It's okay.
Okay. So all the speakers can unmute their mic then.
Okay.
Now I'm muting all the mics, sir. Please unmute the mics.
Dr. Sagar, you can unmute your mic and start your presentation. Yeah. So we'll be having a presentation on normal tension glaucoma diagnosis and management by Dr. Sagar. Bhargava.
Dr. Sagar, sir, please unmute your mic.
Yeah. Can you hear me now?
Yes, perfect.
We can hear you and we can see the slides also.
Great. So good evening, everybody. At the outset, let me thank Dr. Maneesh for this invite. And I really want to commend Dr. Satyajit Sinha and really applaud him for the humongous effort that he has undertaken for last almost a month conducting this webinar for the postgraduates. Really, it's a great effort on his part. So I'll be speaking about normal tension glaucoma. And when we talk about postgraduates, I understand that any topic for postgraduates is important if it has a potential to be asked in exams. And I believe normal tension glaucoma is one of them. But let me give you some reasons to explain the importance of this topic. It goes beyond this short-term target of exam, because if you understand this topic well, if you grasp this topic well and use this knowledge in your clinical practice, your ability to differentiate different types of glaucoma will improve, and you'll be able to give diagnosis to each and every patient of glaucoma. You will be able to save an eye going to blindness, because you will be able to pick up risk factors which are causing that progression. You will be able to improve the systemic health of a patient, because there are many systemic associations which you will treat and the patient's systemic health will improve. Finally, you can actually save a life by actually doing a proper workup, and who knows, you might diagnose a neurological tumor there and you might save patient's life. So let me start with this couple of examples. This is a 39-year-old lady who had a IOP normal range with a history of migraine. So you can see the optic disc in the right eye was essentially normal, but in the left eye, you can see that there was a very, very early notch, a focal area of loss with an RNFL defect, and in the right eye, visual fields were normal. Left eye showed the inferior defect. Another example, 65-year-old gentleman came for an opinion. He underwent cataract surgery elsewhere, and the operating surgeon actually referred the patient to the neurologist. And he came to me for an opinion, and you can see the optic disc. So right eye was significantly excavated disc, and the left eye had an inferior rim loss along with the RNFL defect. And this was the clinic. This was the visual field. You can see significant field defect in the right eye as well as in the left eye. So in the normal scenario, we would label this patients as normal tension glaucoma. The question is whether to treat or not to treat, what investigation you will do, whether neuroimaging is must, what kind of follow-up protocol you will do. So hopefully during the end of our presentation, we will have answers to all these questions. So what is normal tension glaucoma? So normal tension glaucoma is essentially a progressive optic neuropathy where the IOP falls within statistically normal range, that is 2 standard deviations from the population mean. Ravi just explained more than 2 standard deviations. This is less than 2 standard deviations. So anything which is less than 2 standard deviation, will be considered as normal tension glaucoma if it is associated with a progressive optic neuropathy. This is very important to understand. Now, what makes normal tension glaucoma unique? Now, we are all aware that in medicine parlance, when you don't know anything, you label it conveniently as idiopathic. Similarly, in glaucoma, it's a very, very common tendency and habit that you see a patient with a normal pressure and you see some cupping and you just diagnose this patient as a normal tension glaucoma. I call this as a diagnosis of convenience. Second point is that 50% of the patients that you diagnose as NTG will never progress, and fraction of the patients who are on adequate treatment may still progress. So even adequate treatment may not suffice. That's the reason why it is very unique. Now, why does this happen? It's because we still don't know whether NTG is a variant of primary open-angle glaucoma or it is a manifestation of various ocular and cystic conditions. If you look at the prevalence of NTG, we need to understand this, that NTG is a part of primary open-angle glaucoma as of now, today's literature. So when you look at primary open-angle glaucoma, it's a prevalence is around 1 to 4%. Out of that, you see more than 50% of the patients have actually normal tensions. In fact, a study from Japan showed almost 92% patients of primary open-angle glaucoma were actually normal tension glaucoma. Now, in order to actually do an effective management, it's very important to understand pathology and etiology of this condition. It's a very controversial topic, but unless you understand this, you will not really be able to investigate and treat. So essentially, there are two important points here. One is an IP-dependent mechanism, second is an IP-independent mechanism. Now, in normal tension glaucoma, even though the IOP remains in the normal range, it can still induce damage to the optic nerve. Now, this has been proven by this landmark trial called as collaborative normal tension glaucoma trial, where they've actually divided normal tension glaucomas into two arms. The treatment arm where they reduced the pressure by 30%, and the observation arm where they did not do anything. So treatment arm actually showed reduction in the progression of the visual field loss. So one thing was clear that IOP reduction helps. That means IOP was one of the factors in causing damage. Another concept that is now gaining importance is this concept of translaminar pressure. Here, essentially, we all know there is something called as lamina cribrosa through which our axons actually pass. So across the lamina cribrosa pressure, there are essentially two pressures. One is coming from the eye, and the other is coming from the CSF. So these pressures create a gradient. So if normally what happens is IOP is slightly higher than the CSF pressure. Now, if this difference increases, for example, if it's a high pressure glaucoma, the difference will be very high. It will cause direct mechanical damage to the lamina cribrosa and it will cause cupping. In normal tension glaucoma, what happens is the IOP is normal, but studies have shown that CSF pressure is actually little low. So there is resultant pressure effect on the lamina cribrosa, which is responsible for mechanical damage. Now coming to the IOP independent mechanisms. Now this is something that we need to understand even more deeply. So what makes this optic disc susceptible to intraocular through a normal intraocular pressure is something which has been actively looked into. So this is a topic of research. One thing that has come out is that these eyes tend to have thinner lamina cribrosa and a thinner prelaminar tissue. So that might make it susceptible for biomechanical or structural damage. Vascular factors, they are probably the most important etiological factor in glaucoma. To revise a little bit, so what happens in vascular factors is either there is a reduction in the ocular perfusion pressure, or the blood vessels have a vasospasm along with vascular dysregulation. So it causes what is called as reduced ocular blood flow and altered levels of oxygen to the tissue, and that can cause either ischemic damage or oxidative damage. Now, this concept of vascular dysregulation is something which is key to understanding NTG. So what is vascular dysregulation? For that, we need to understand what is autoregulation. Now, autoregulation is essentially ability of the tissue to maintain its blood flow in spite of fall of perfusion pressure. Thus, in conditions where autoregulation is compromised, you will have a direct impact on the blood flow. In our context, it is the ocular blood flow. NTG is essentially associated with different forms of dysregulation, of which one is primary vascular dysregulation, second is secondary vascular dysregulation, which is associated with different autoimmune conditions, and then there is a third category of migraine and Raynaud's. But what is common between all these conditions is something called as an endothelial cell dysfunction. So there you have increased endothelial 1 levels, which is what is responsible for vasospasm and subsequently this vascular injury. Now, Flemmer's syndrome is a relatively newer condition which has been described. It is essentially compromises of comprises of clinical features that happen due to dysregulation of blood supply, which happens because of specific stimuli like cold, emotional stress, and hypoxia. And they are conglomeration of specific symptoms like cold hand and feet, low body index, arterial hypertension. Then they have difficulty to fall asleep and so on. So this is a very important concept to remember. Next is blood pressure. Now, we all know blood pressure is important because it's the driving force to maintain ocular blood flow. Now, and it's a known fact that at night the blood pressure actually decreases. So a 10 to 20% dip is considered as physiological. So whether anything beyond 10% can cause decrease in ocular blood flow, this study which I am just highlighting has shown that. So they basically categorize patients into three groups. One is non-dipper, where the change of pressure was less than 10% at night. Physiological dippers, where the pressure was between 10 to 20% of the daytime BP, and over dippers when the pressure actually reduced more than 20% in the night. So you can clearly see that the visual field loss was much higher in the over dippers compared to non-dippers and physiological dippers. So low blood pressure means there will be low ocular blood flow. That means it will lead to damage to the optic nerve. Then there are certain systemic diseases like obstructive sleep apnea, where combination of mechanical and vascular factors can cause optic nerve injury. A very simple tool is available called a stop bang. This basically is a questionnaire which you can ask the patient, and and this will help you to decide whether you would want to investigate them further for obstructive sleep apnea. Now, obstructive sleep apnea is a condition which happens because of partial or interrupted normal breathing due to functional collapse of the upper airway that leads to apnea and hypoxia at night. So these are intermittent episodes, and they induce increased sympathetic activity and vasoconstriction. Another concept is there which is called as impaired CSF circulation. Now, CSF circulation has a very important role in nutrient delivery and clearance of metabolic waste. And accumulation of, if it is hampered, it will lead to accumulation of toxic compounds, and that will lead to death of RGCs. Optic nerve canal in NTG patients have found to be narrower. That may be one of the reasons for this. Alzheimer's disease is another association, and there the stagnation of CSF have been found to CSF stagnation is one of the things that has been found in Alzheimer's. So having understood the etiology, pathology, and pathogenesis, when we come to a clinical evaluation, you should have three broad categorization in your mind when you see a patient. So you need to first differentiate it from other forms of glaucoma. You need to differentiate it from optic neuropathy, and you need to look for non-IOP dependent factor. So if you categorize these three things, you will not miss anything. So first thing is the history. So when you talk about history, you need to ask patients specifically if there is a history of pain and decrease in vision. So it can have, or certain things which can just cause intermittent rise of IOP without causing any symptoms. So these are the lists. So you can get it in intermittent angle closure, history of intermittent steroid use, specific yoga postures. Some people have a habit of taking large water intake. Then certain Valsalva maneuvers like conch blowing and playing wind instruments can all give rise to intermittent rise of IOP. Then sometimes you can have single event that can be there that can cause hemodynamic shock, for example, in blood loss, or trauma, which can cause hyphema, and the pressures may be elevated for a month or so, and then ultimately it settles on, and that's the time when the damage happens. Then you need to look at non-IOP risk factors, which we had just discussed. So you need to look for history of headaches, for migraine, blood pressure record, history of use of antihypertensive. When is the dosage taken? So if it's a nighttime dosage, that may be one of the reasons. History of snoring and all the symptoms that we discussed about Flemmer's syndrome. Neurological, yes, you need to ask them about antituberculous treatment. You need to ask them specifically for any SOL treated or patient is under treatment. You have patients who have had SOL removed about 25 years back, and subsequently 10 years down the line, they underwent perimetry and they found some defect and they're on treatment. So this has happened with one of my patients actually. So this history is very important. Coming to the examination part also needs some time. So you basically, when you evaluate this, you need to look at vision, color vision, pupil, because that might give you clues to the neurological condition. Careful slit lamp examination will help you to give clues for pseudoexfoliation, pigment dispersion, trauma, etc. Gonioscopy is very important. We need to have the angle has to be open. We need to rule out that there is no pigment dispersion there. There is something called as a burn stage of pigment dispersion glaucoma, And that happens when the patient actually from a high pressure has become now normal pressure. And a classical sign that is seen in that is called as a pigment reversal sign. So normally what happens in pigment dispersion, you get more pigments in the inferior angle. In the pigment reversal sign, you get pigments more in the superior angle. So that may be an indication of burnt out optic neuropathy. Coming to the disc examination, disc, you would look for focal defects or focal notches that are more common than primary open angle glaucoma. And you will look for disc hemorrhage. Disc hemorrhage is the most important finding which will give you a clue towards normal tension glaucoma. And when you talk about disc hemorrhage, these are basically present in prelamellar areas and superficial nerve fiber layer. They are usually, and any hemorrhage which is within 1 disc diameter from the disc margin can also be taken as disc hemorrhage. Exact cause we don't know, but it can happen in 1% of normal population. But if you look at NTG population, it is definitely much more in NTG population compared to even a normal primary open angle glaucoma population. It usually clears in 11 weeks. A point very important to understand this is then when it is clearing, it is very difficult to pick up. So you need to look at this sign very carefully. And recurrent disc hemorrhage is very important because that when you document it, if it is a recurrent hemorrhage, that means the condition is not at all under control. CCT is important because if a patient is having a pressure of 20 with a CCT of 460, so we are not dealing with the NTG. It's basically if you correct it for CCT, it becomes a primary open angle glaucoma. So CCT is important. HVF, OCT, and disc photo is important for documentation and further progression. You need to differentiate it from various other forms of optic neuropathy. I will not go to details, but you can do certain blood tests and other things to rule out those things. Now, this brings me to another important concept of neuroimaging. So there are many instances, both in literature, even in routine clinical settings, where many patients have had compressive optic neuropathy and they have been treated as NTG. And even surgeries have been done for glaucoma. But they were actually patients having some or the other lesion in the neural line. But should we do neuroimaging in all patients with NTG? Actually, studies have shown that doing neuroimaging in all patients may not be so cost effective and yield actually may be low. So you need to look at certain atypical features like lower levels of visual acuity, neuroretinal pallor, poor correlation of pattern of visual field loss versus and optic disc coupling, and a vertical line length. Just to share you a very interesting example, this patient came to me for a second opinion. He's an 82-year-old gentleman with IOP of just 12 millimeters. And if you look at his visual fields, 2007, his visual field was like this. He was started on treatment, and he was, and then every few years they would repeat the visual field and add one more medication. So now you can clearly see that there is a temporal defect which is responding the midline, and all we had to do was a neuroimaging, and it turned out to be a pituitary adenoma. So you have to keep your eyes open, see where the defect is. If it is in the atypical quadrant, or if it is respecting the vertical midline, you need to investigate. So look, the last thing probably would be to look for non-IOP dependent factors. If nothing else, you're able to get it. If the condition is still progressing in spite of treatment, then probably a 24-hour BP record, a sleep study, nail fold capilloscopy, and color Doppler imaging to assess the ocular blood flow can be undertaken. I'm not going to go into details of this. Just to show you how a 24-hour BP record can be helpful. This is from one of my patients. You can see this patient was progressing in spite of the best of treatments. You see how much the IOP was fluctuating in 24 hours. Systolic fluctuating from 168 to 102, and diastolic from 71 to 41. So there's a huge drop at night, and that can cause reduction in the blood flow, ocular blood flow. Carotid Doppler definitely can be undertaken because some patients can have significant flow obstruction, which can give rise to optic nerve damage. Now coming to how do you manage these patients? So again, you need to take the clue from this study, which tells us three important things: that 50% of your patients will never progress. In patients who are progressing, treatment will definitely help, and some patients will progress faster. And these being female patients from female sex, history of migraine, and presence of disc hemorrhages. But you understand one thing, you can still observe some patients, like patients having just mild visual field defect, no risk factors for progression, and you follow up to see whether they are progressors or non-progressors. So IOP lowering treatment definitely is needed in some in a group, and you aim for 30% reduction, and you can use any of these. Choice of treatment would be prostaglandin analog because they have the best IOP lowering capabilities, and they have a very good nocturnal IOP control. In fact, latonprost has been shown to have some kind of neuroprotection also. Now, I'd like to also highlight this study, which is a recent study, which essentially compares brimonidine with timolol. And what they found out was that IOP reduction in both the groups were were similar, but there was less progression in the brimonidine group. Now, why did this happen? Now, this difference due to additional neuroprotective effect of the brimonidine, or was it the detrimental vascular effect of the timolol? The answer is unclear, but this clearly shows that IOP reduction is not enough. So in short, you have to avoid beta blocker because their IOP reduction in nighttime is anyway less, because nighttime aqueous secretion reduces, so it will not make too much of a difference, and they have a direct effect on the blood pressure that can cause reduction in the ocular perfusion pressure. Alpha agonists, yes, because they act in two ways: decreases the aqueous production and increases UV sclerotic outflow. They also, in animal studies, have shown to have neuroprotection effect. Carbonic anhydrase inhibitors, they have been shown to have definitely a good amount of increase in ocular blood flow, and they cause darzolutamide has actually been shown to cause some amount to give some amount of neuroprotection. Surgery may be needed if there is if nothing is working, but you can aim to bring IOP in the single digits also. Since a lot of systemic factors are there, you would probably need to do some bit of lifestyle modification, like you need to ask the patient to stop smoking, regular exercises should be done, avoid certain yoga exercises and breath holding maneuvers that patient must be doing. Lateral cubitus position can be avoided. And something which has come up recently is to avoid smartphone in patients who are around 20 to 40-year-olds, young patients with NTG, because it has been shown that anything more than 25 minutes of smartphone use can cause increase in IOP, which is more than normal patients. So in short, this is the flow chart, how you will approach. So first thing, you will make sure that you have ruled out all the other forms of glaucoma, and you have done a diurnal which shows that it's a normal range for IOP. You see that there is a disc suspicion, you do a visual fields and OCT, and if it comes out to be normal, just put the patient as normal tension suspect, establish a baseline data, follow up and look for a change. If you find it is abnormal, the next thing is that you have to rule out a neurological cause, understanding the risk factors that we discussed, and if that is ruled out, then it's a confirmed NTG, establish a baseline data, you can observe them or you can treat them. Treatment, look for progression. If it progresses, then you investigate for risk factors. So coming back to our two cases, so this lady who was having a little bit of defect here, we decided to observe, and it's been 4 years, she has not shown any progression. This gentleman, actually, when we investigated him further, he did give history of snoring. We did a sleep study for him, and it turned out to be a severe form of obstructive sleep apnea. So he was on anti-glaucoma medication along with CPAP treatment. This actually improved his quality of life because the oxygenation levels improved. So to conclude, I would say that normal tension glaucoma is an enigma because we still don't know whether it's a one-time damage, because 50% of patients will not progress, whether it's a POAG variant because some patients will still do respond to IOP lowering, whether it's a neurodegenerative condition because of its association with Alzheimer's, or whether it's an optic nerve disease in a sick body, say patients with vascular dysregulation, or it's a disease optic nerve in toxic CSF environment. So studies are going on. In fact, it is one of the most researched topic in glaucoma, very controversial. But what you need to understand is that you individualize your patient and give them treatment based on whatever clinical findings you have. Thank you for your kind attention. Thank you.
Thank you, Dr. Sagar. I think it was a very comprehensive presentation. Almost all the important points were nicely covered. Dr. Ravi, Dr. Ravi is there. Madam, are you there? Yeah. So I think we just have another 10-15 minutes where we can share a few questions. There's one question for Dr. Sagar, that what is the rationale for deciding target pressure for NTG, upper teens, lower teens? So anything you want to touch about how to calculate target pressure for NTG patients?
Yeah. So the one thing we have to understand is that there is no magic figure as far as target IOP is concerned. What you need to understand is that, am I audible?
Yeah. Audible.
So what we need to understand is that we need to reduce the IOP by at least 30% of whatever level that we have got, and we need to follow these patients probably with frequent perimetries to see whether that fall in 30% has stabilized the visual fields or not. So stability of visual field is what you are looking at with the fall of IOP. And if it doesn't fall, if it doesn't remain stable, then you need to add on medication. So 30% would be probably the initial target of reduction. but there cannot be a magical figure. You have to basically evaluate each and every patient.
Exactly. So we have to keep reassessing our targets. Ravi, I was asking you about the scoring system. There are certain scoring system available based on ocular hypertension treatment study and all. Do you think these scoring system are useful for ocular hypertensive patients? Ravi, you need to unmute your mic, Ravi.
There are scoring systems available to know the risk involved in OST, but once we start entering some of the values there, like say age, IOP, PSD changes, by doing entries of 4, 5, or 6 cases, we come to know like what values it is giving. So over a period of time, we understand that without going for the scores also, by itself we can know that how is the risk involved. If it is a high risk case, we can start with the treatment. If we feel that the risk is low, so after 4 or 5 entries, usually everybody understands so what result we are going to get. Initially, yes, we can use, but later on we can use our clinical sense itself.
Very rarely you will see any clinician or a glaucoma expert using the scoring system, but initially, as Ravi has mentioned, you can start using it for few cases, then you will get an idea that what are the key points to note and how to like assess the risk of progression, and based on that later on. Madam, one interesting question that why females have poor angle posture and why there is interatrophy and not a dilatation.
I don't think there's any known reason for that. Probably anatomical predisposition. Females do have smaller eyes, and that probably predisposes them more to angle closure problem.
Madam, there is another question. Any tips about doing endoscopy in hazy cornea? For example, even in acute angle closure or triopy rise, even sometimes in neovascular glaucoma, corneas are very hazy. Any special tip you like to share with the student?
So most of the time we are get some movement into a face by using a little minor manipulations, or something. If you are able to get at least you are able to see whether the angle is open or closed. As long as it is not a totally opaque cornea, you would still be able to get some kind of if there is epithelial edema, the only thing is you have to think about keeping your gonio mirror. If you're going to scrape off the epithelium, then that may be a little tricky. You think of doing all this maybe in setting, but in the outpatient probably would do that.
I think there is some connectivity issue. I am getting. I'm not sure whether others are okay or there are some issues with audio. But Sagar, you can take this. What is the relationship between hypertension and
Can barely.
Your voice is slightly breaking, sir.
my voice
Hypertension
is
and
also breaking? Am I audible now?
Yes, sir. Yes, sir.
Yeah.
Okay. So what is the relationship between blood pressure or hypertension and glaucoma? Is there any association? And there is another question that what is the relationship of high BP and glaucoma? So that's sort of similar type of questions.
So blood pressure can affect on both the counts. Very high pressure on a long-term basis can cause ultimately tissue ischemia that can deteriorate condition over a longer period of time, but it will not give rise to sudden episodes. Now, sudden episodes as vascular events usually happen when you have decrease in ocular perfusion or ocular blood flow, and that happens typically with the fall in blood pressure. And that for that reason, you have to make sure that the patient doesn't have nocturnal hypotension. So we were quite surprised that number of people who have low blood pressures at night is pretty high, and that's the reason why now 24-hour blood pressure monitoring has become one of the important parts of our workup in patients who progress. So blood pressure control is very important. I did not go into those things like ocular blood, ocular pulse, ocular perfusion pressure, and all those things because that is beyond the scope of this class.
So basically, nocturnal hypertension is very important, especially for normal tension. Glaucoma is really important. We need to look into a 24-hour BP assessment. And madam, you can take this question: how to calculate baseline intraocular pressure? That is related to timing of the day a number of times we should check the baseline pressure to decide what is the baseline IOP. So when you are assessing a baseline IOP, do you do it at a particular time or you check multiple pressure? How you actually set a baseline pressure?
This in reference to NTG or I don't know.
I think it's the general question, whether it's open angle glaucoma or NTG or even ocular hypertension. We often mention that we should have a baseline IOP. Baseline IOP for you is the one IOP or the group of IOP, or how you actually set the baseline.
So if at a given checkup, if say I see a patient has a pressure of 32, he has an inferior north and a corresponding damage, there's nothing amiss, then I really don't go on to do a diurnal variation. Diurnal variation, to get your baseline, I reserve it mostly, say, for example, in ocular hypertension or in a normal tension, where you want to know what's the amount of fluctuation that is happening. That is only in those situations I look at getting a diurnal variation. Otherwise, if the pressures that you have recorded are correlating with the discontinued finding, then I don't think it's mandatory to do a diurnal.
Thank you, madam. I think there is one last question Sagar can add to this. What is the cutoff limit of diastolic BP below which it can affect ocular perfusion pressure? Is there any cutoff?
Maneesh Gupta ji, can you mute everybody and then we will be four of us, five of us mute ourselves?
Okay, sir. Yes. Now you can unmute, sir.
Yeah,
Respective speakers, they can unmute their mic.
Okay. Go ahead, Sagar. Sagar, unmute yourself.
Yeah.
Sagar, unmute yourself.
Yeah. So there is no magical figure as such. So essentially, you look at a complex calculation of diastolic pulse, diastolic blood pressure. Anything below 60 would be probably a problem at night. So that is something that you need to look at. But there are studies which have been done. I think I have a slide also on that. I'll just share with you 1 second. So there is something called as diastolic perfusion pressure, wherein you essentially subtract the intraocular pressure from the diastolic blood pressure of the patient. And that value, if it is less than 50, it varies from in different studies. But consensus is that anything less than 50, these patients tend to have a little higher risk of damage. So diastolic perfusion pressure, that means you have a mean diastolic value at night, you subtract the mean IOP at night, and you get a value. And that value is something which will give you an idea as to what is the risk of damage for that patient. And that is very difficult to do because you have to measure blood pressure along with IOP same time. So practically in clinical settings, that may not be helpful, but a lot of studies have been done and they have come to this conclusion that anything which is less than 50 diastolic pulse pressure is significant.
Thank you so much. I think this is all the questions we had. So I'd like to thank all the speakers, Sathi Devi Madam, Dr. Sagar and Dr. Ravi. And I'll hand over the session to Dr. Satyajit.
Dr. Satyajit, I had a question for me. I missed the question because voice was not clear that time.
Yeah, I think
Can you hear me now?
Yeah, the voice is clear.
I was saying that in this Indian scenario where we have so many patients lost to follow up, if you have a patient of ocular hypertension and there is no field changes and everything is within normal limit, the patient realizes that he doesn't have follow up.
There is some issue with.
Again, the voice is not clear. I'm not able to hear you.
Can you hear me?
No, the voice is not clear.
There is some connectivity issue, I think, going on. So,
Patients developing glaucoma who are the hypertension patient. Doesn't matter. I'd like to thank everybody. I would like to thank Dr. Maneesh. I'd like to thank Dr. Sathi Devi. I'd like to thank Dr. Sagar and Dr. Kumar for having put their time today.